Post-operative care. The post-operative period begins when a client is admitted to the post-anesthesia care unit, or PACU, also known as the recovery room. The recovery room will be located near the operating room, which enables the surgical and anesthesia personnel to be readily available for any emergencies. The anesthesia personnel and circulating nurse will then transport the client to PACU. Anesthesia personnel stays with the client until they are assured that the client has a good airway and overall is stable. The PACU nurses are knowledgeable in caring for clients recovering from anesthesia. That initial postoperative nursing management, we refer to the Aldrich scale to help determine when those clients are, when they do meet criteria to be discharged from the ACU. They look at airway patency, effectiveness of respirations. Do they have any artificial airways in place? Do they require mechanical ventilation or oxygen? They look at the circulatory status, including wound condition, the dressing and drains, and the amount of drainage. They look at fluid balance. So what IV fluids do they have going? How fast are they going? What is the catheter output if they have a urinary retention catheter? What are drain outputs if they have drains? They look at level of consciousness and pain. The nurse also monitors for level of consciousness and for potential complications. Again, the Aldrich scale is a tool that's used to assess how well a client is recovering from anesthesia, and it rates on the client's mobility, respirations, blood pressure, level of consciousness, and pulse oximetry. This is a copy of the Aldrich scale, and a copy should be located in resources on Blackboard. Postoperative complications include hemorrhage. The PACU nurse will assess for symptoms of shock. They inspect the dressings, continue or initiate blood transfusion, reinforce dressings, monitor the wound drains. Shock is another complication, and we have fluid and electrolyte loss, trauma, anesthetics, medications, all of these contributing to shock. We treat it with blood plasma expanders, IV fluids, oxygen, and medications if necessary. Hypoxia is the next complication. This can be caused from residual drug effects, pain, client's positioning. Is their head tilted forward? Is their airway open? Pooling of secretions or obstructed airway can also cause hypoxia. That decreased gag reflex or swallowing reflex. Oxygen and suction equipment should be available, and the nurse is always assessing for signs of cyanosis and dyspnea. Aspiration is the next complication. Aspiration of saliva, mucus, vomitus, or blood can occur until the client is awake and able to swallow without difficulty, and that gag reflex is returned. Again, having suction equipment at the bedside, assessing for difficulty swallowing, or putting the client in a sideline position should be helpful. Wound dehiscence is separation of wound edges without the protrusion of organs. This complication is likely to occur within 7 to 10 days postoperatively. Risks will include poor nutrition, chronic diseases, an older adult, increased abdominal tension, obesity, and infection. So it's very important to decrease the strain on the incision and notify the surgeon if this occurs. Evisceration is the complication of wound separation, but now we have the protrusion of organs. We cover this wound with sterile dressings that are moistened with normal saline and immediately notify the surgeon. A paralytic ileus is the next complication. We have paralyzed intestines and no peristaltic activity. It may require a nasogastric tube and an NPO status until the bowel sounds return. Pneumonia and atelectasis. Atelectasis is the collapse of alveoli. These are both possible due to drug effects and failure to take deep breaths and immobility. The older adult is most at risk for these complications, in addition to the added risk of obesity, clients that have COPD, or clients that have had chest or abdominal surgery because it hurts to take a deep breath. Infection is the next complication. It's indicated by increased wound pain or drainage, and that drainage does not have to be purulent. Erythema, increased warmth, edema, and purulent exudate. Increased body temperature. This condition will probably require some antibiotics. Infection risk is increased with traumatic wounds, wounds that were not treated promptly, or wounds that were infected preoperatively, in addition to clients that are obese, immunosuppressed, or have diabetes mellitus. And the last complication we're talking about is thrombophlebitis. This is inflammation of veins with the formation of blood clots, usually caused by long periods of immobility. These clients are going to be at an increased risk for pulmonary emboli, where the clot breaks off and travels to the lung. The clients that are most at risk for thrombophlebitis are those that have surgery or issues from the hip down, but anyone who has increased mobility is at a risk. We can treat it with anti-embolism stockings or sequential compression devices to help reduce that risk of blood clot formation in the legs. Later postoperative nursing care is going to begin when the client arrives back to their hospital room or the post-surgical care unit. The assessment will include everything that the PACU nurse assesses, and it just basically starts all over. So this includes the respiratory status, circulation, pain management, fluids, nutrition, skin integrity, wound healing, activity, bowel elimination, urinary elimination, and psychosocial status. The nurse should assess respiratory and cardiac function, general condition, vital signs, fluid status, pain level, elimination and flatus, dressings, drains, and IV lines. With the respiratory status, make sure that the nurse is encouraging deep breathing exercises, the use of an incentive spirometer, and splinting of the incision, providing supplemental oxygen as necessary, encouraging frequent position changes and early mobilization. The circulatory status requires assessment of blood pressure and potential orthostatic hypotension, assessment for bleeding and venous circulation, impairment in the form of deep vein thrombosis, which could break off and become pulmonary emboli. Postoperative pain will be its greatest 12 to 36 hours post-procedure, and pain should be treated before it becomes uncontrollable. Pain that is unrelieved by medication can indicate complications. So one of the medications we may give postoperatively are opioids. They are used to relieve moderate to severe pain and can also be used in conjunction with anesthetics. They suppress the cough center. Codeine is the main one that helps suppress the cough center. But it can also, morphine, for example, can decrease the workload of the heart. It can also decrease anxiety and decrease oxygen consumption. Adverse effects of opioids include constipation, strong abuse potential, flushing and orthostatic hypotension, sedation, nausea, vomiting, urinary depression, respiratory depression, and confusion. Very important that we don't give this in cases of severe asthma or respiratory insufficiency or an elevated intracranial pressure. There are some other issues, but those are some of the important ones. We need to be aware that if we're administering opioids, we need to be prepared to treat for potential overdose, and this would be our naloxone. Opioid agonists will bind to an opioid pain receptor in the brain, causing an analgesic effect. Examples include codeine. Antitussive is what codeine can be. It also has a ceiling effect. In other words, administering a higher dose of codeine is not going to improve pain relief. Fentanyl is the next one. This is injectable, but it can also be administered topically or orally. If we do it topically, this is usually transdermal for chronic pain. Breakthrough pain, if we use that transdermal, may require the administration of an immediate release opioid. Others include hydromorphone. Meperidine is also known as Demerol. It's kind of lost favor in recent years because of its high risk of toxicity. Methadone, this is often used in detoxification of opioid addicts. And morphine and oxycodone are also included. Excuse me. Agonists, antagonist opioids are also known as partial agonists or mixed agonists. They're going to bind to a pain receptor and cause a weaker pain response than a full agonist. This type of medication also avoids oversedation, so it's very useful in obstetrical clients. It's also useful in treating opioid addiction because there's a decreased risk for addiction or dependency. The one that I am most familiar with is nalbuphine, also known as Nubain. Opioid antagonists are going to bind to a pain receptor, but it does not reduce pain signals. And this is what we refer to as naloxone or Narcan. It will reverse the effects of the opioids. So if we administer naloxone, be aware that within a few minutes, their pain levels are going to be very severe again. But it does work very quickly. The next thing that the surgical unit nurse is going to monitor are fluids and nutrition. This will include IV fluids. We'll have a dietary progression that's dependent on the type of surgery. um, the client's progress, their physician order. We always need to assess for nausea, vomiting, bowel sounds, flatus. A nasogastric tube may be placed post-operatively in a client that's had abdominal surgery. Nursing guidelines for resuming oral fluids. We keep them NPO. We assess their bowel sounds, remembering that GI activity may not resume for 24 to 48 hours. So if they've had like a big bowel surgery, big abdominal surgery, we do not expect to hear bowel sounds for a couple of days. If we hear it before, that's awesome. But if not, 48 hours is pretty average. We also need to, before we begin administering any medications, assess swallowing, introduce sips of water or ice chips slowly, usually 4 to 24 hours postoperatively. Once again, unless it's a GI surgery. In that case, they can stay NPO much longer. Make sure we administer antiemetic medications if the client is nauseous or vomits. And when able, we will be promoting protein, calories, vitamins A, C, and zinc for wound healing and immune system function. The nurse then monitors skin integrity and wound healing. Different devices the client may come back with would be some of the drains, and these are going to remove fluids and air from the wounds. They can remove fluid passively or actively with suction. A Pinrose drain is a flat silicone type drain that's placed deep within a wound and lies flat on the skin outside a wound. It kind of resembles the neck of a balloon, for example, for an illustration. And then we put a sterile safety pin in it to prevent it from sliding all the way into the wound. There's a Jackson Pratt or Reliavac drain that is a hollow silicone bulb with a cap on it. That cap, the bulb itself is actually attached to a silicone tube that is placed near the wound through a stab site. To activate the suction, we take the cap off of the bulb, we squeeze the bulb tight, and then replace the cap. As it begins to open back up, it's actively pulling fluids out of the wound. The bulb is often secured to a dressing or the client's clothing with a safety pin through the tab attached to a bulb to help prevent dislodgement. And often that tube is sutured to the client at the stab site. Another type of drain is a circular drum-shaped spring-loaded drain. It's often referred to as a Hemavac, and we frequently will see this with our orthopedic surgeries. So just like with the Jackson Pratt or JP drain, when you have that cap open, you then squeeze it tightly closed and then replace the cap. You decompress that drain and then replace the cap. Again, this drain can be secured to the client with a suture. It's also a type of drain that may have the option of reinfusing sanguinous exudate, so basically reinfusing blood, usually within 4 hours postoperatively. This drain has a clip similar to those that you find on Foley catheter tubings to help secure it to the bed or the client's clothing. Some clients may come back with that nasogastric tube inserted through one of the nares, and it is often attached to low intermittent suction. These tubes are then secured to the client's nose with adhesive of some type. It may be tape, it may be a special securement device. The tube is then often secured to the client's gown to help prevent dislodgement. Wound assessment will include assessing the approximation of the wound edges, making sure they're together, the intactness of staples or sutures, looking for signs of infection, and reactions to the adhesive or the dressing itself. Phases of wound healing include the inflammatory stage, the proliferative phase, and the maturation/remodeling phase. With the inflammatory stage, we're often going to feel a little extra warmth right along the incision, a little bit of redness, and a little bit of edema. That is normal, so it's not to be confused with signs of infection, which are going to also include pain or increased exudate, a purulent exudate, etc. There are 3 modes of wound healing. We have primary intention, which is the healing of a wound with the edges that are well approximated with sutures or staples. In other words, it's closed well. Secondary intention is the healing of a wound from the bottom up, but the edges are not approximated. In other words, we leave the wound open. And tertiary intention is leaving that wound open initially, and then we go back to suture it at a later time. Factors that affect healing include impaired circulation, malnutrition, hyperglycemia, infection, the remainder of foreign bodies in the wound, the client's age, and immobility. Signs of wound infection include increased incisional pain, redness, swelling, heat around the incision, purulent drainage, fever, headache, and anorexia. Complications of infection include dehiscence and evisceration. Nurses also need to monitor activity. Advance activity as tolerated by the client as soon as possible. This helps decrease complications, and it's actually the magic cure. It doesn't happen right away, but it does improve things so quickly. It decreases their pain faster, allows them to go home faster. It increases circulation. It increases the bowel activity, the urine output, etc. With regional anesthesia, activity is initially restricted until feeling returns. With a regional anesthesia, such as a spinal anesthesia, a spinal headache is not unusual. So these clients may remain lying flat for a longer period of time. We need to make sure that we are administering pain medication to encourage activity. Take away that excuse of, oh, it hurts too much, I can't do this. We monitor bowel elimination. If the client has abdominal distension, this can be caused by narcotics, the client's diet, and inactivity. We need to encourage the client to ambulate, frequent position changes, and advanced diet as tolerated. A paralytic ileus is that paralyzed intestine, and we will see acute gastric dilation as that stomach begins to dilate with fluids. Urinary elimination can be difficult after surgery. So if a client is unable to void within 8 hours postoperatively, we encourage voiding, but it may require straight cathing this client. But we give them, again, up to 8 hours before we get overly concerned. There are several different things that we can do to help encourage that elimination. Encourage fluids, running water in the sink, pouring warm water over the perineum, giving the client privacy, allowing them to actually sit on the toilet or stand at the bedside can also be beneficial. But we do realize that some of the anesthesias or the opioids can cause urinary retention. We assess their psychosocial status. This can be altered because of changes in body image or lifestyle. So we need to assess for issues and refer for counseling or support groups as necessary. Gerontological considerations postoperatively. Remember, the older adult can develop confusion and disorientation with narcotic and barbiturate use, not to mention the anesthesia. Respiratory depression risk is also greater in the older adult with narcotics. Older adults may have a delay in healing because of thinner skin and loss of subcutaneous tissue, and they are at an increased risk for infection due to a diminished immune response. Question: which intervention would be indicated for a client with thrombophlebitis of the leg? Encourage fluids, encourage fluids by mouth. We want to make sure we keep that blood thin as possible. So we need to make sure we have plenty of fluids. Remember, dehydration causes increased viscosity of the blood. So discharge instructions. When we're ready to send these operative clients home, we need to provide this verbally and in writing, and make sure that a significant other is in on the education, or at least knows where the written instructions are, along with any potential prescriptions. Determine the client's needs, including their ability to care for themselves. Do they need supervised home care? Do they have appropriate supplies? Are there any special dietary needs? Any issues in adjustment to the living environment? Making sure they have pain medications and or understand how to take them. Discharge instructions should also be reviewed once again with that responsible adult other than the client. And these include medications. And always review medications they've been on before. Maybe no one has ever provided education before, and what you tell them is the first time they've heard anything about that medication. But definitely include those new medications. Wound care. The best way to provide instructions on wound care is to let them watch and then let them do it. Activity, including bathing and driving. What are they allowed or not allowed to do? What diet should they be following? When should they notify their healthcare provider? And we're not talking complications. Usually this is going to be symptoms of infection, or the wound has reopened. We don't provide surgical complications. This is preoperative education. But we just provide issues that when they go home would require them to be notifying their physician. And we need to encourage them to keep all of their follow-up appointments.